All right, so 7:04, so I guess we will get officially started. So thank you all so much again for joining us tonight. I am incredibly pleased and honored to have Dr. Fumiko Chino joining us tonight from New York, from Manhattan. And also Dr. Smith is joining us from Columbus. And I put these slides up to make it clear that you are in the right place once you log in, because sometimes I log into these events, I'm like, am I in the right place? And I will tell you a little bit about Dr. Chino. So she is a cancer researcher and assistant attending in radiation oncology at MSK in New York. She graduated from Duke School of Medicine, and she was the chief resident there. And she also served as the teaching value fellow at the Cost of Care Group, a global NGO focused on affordability in healthcare, which is an incredibly important area. And her research is focused on the financial toxicity of healthcare, cancer care disparities and access, and patient-reported outcomes and shared decision-making, survivorship, and end-of-life care. I will also introduce Dr. Smith, who is originally from Chicago, and she majored in education at University of Illinois in Urbana-Champaign. After graduation, she taught elementary music in Florida, and she still very much has the teacher in her for all the good reasons and all the good use. She graduated from University of Florida Medical School in 2015 and had her first daughter right after medical school graduation. Then she completed her intern year at University of Florida and now is in her last year of radiation oncology training here at Ohio State. And as of today, she received her big girl's job offer in Florida in a private practice, so yay her. And her special
yet, but it was exciting.
And her special skills include she had her second baby, her son, during residency, and as you can imagine, she has quite a few battle scars from that and a few stories to tell. Now, I was born in Prague in the Czech Republic, where I got my MD in 2009, and I started my PhD that year at University of London, which I finished in fall of 2014. And that same year in December, I started as a postdoc at Columbia University, where I stayed for about 2.5 years. And then I matched to residency in radiation oncology and did my internship in New York in the South Bronx at Lincoln Medical and Mental Health Center. And now I'm a fourth-year resident here at Ohio State. My research focuses mainly on data science, big data, machine learning, epigenetics, and cancer outcomes. To kind of set the mood for tonight, I wanted to share this quote with you. We never talked about men or clothes. It was always Marx, Lenin, and revolution, real girls talk. So I'm looking forward to many of your questions. And now I will stop sharing my slides if I click the right button. And I will ask the first question that I received, which is for Dr. Chino. And I think, all of you know what radiation oncology is and what it's about. But at the same time, I would like to ask her, if you were to describe to people who are not familiar with the field, what is radiation oncology like?
Sure. So I feel like I'm uniquely qualified to talk casually about this because not only am I a woman in radiation oncology, but I was actually raised by a woman in radiation oncology. So my mom actually has 7 kids, 5 of which she had during essentially medical school residency. And I was one of those babies. So I feel like know kind of both sides of it. The overall practice of rad onc is outpatient, which is, I think, a nice balance. There's very little to any inpatient coverage in terms of kind of your schedule. And then your kind of main dividing line in terms of your time depends on if you're going to go into academic medicine or if you're going to go into private practice. And that's sort of generally true for many medicine disciplines. And so for me, I'm in academic medicine, and most of the time I spend is actually balancing the kind of research and patient clinical care kind of paradigm where you feel like you're never quite doing enough for either of them, but patient care always comes first. So if it's going to be a balance, it's going to shift towards patient care for when those needs are more heavy. So outpatient care, balancing clinical care, seeing patients, making radiation plans, and then doing research. I would say in my spare time, but I'm actually a 50-50 kind of position. So when I describe what I do to patients, though, what I tell them is that basically my job is to kill cancer or reduce the risk that cancer would return, and to minimize any kind of late side effects that you may feel. So the benefit I've found from this career for me personally is that I do really get to forge these long relationships with my patients. During treatment, you're going to see them once a week, and then kind of long term, I see people in follow up as frequently as every 3 months for a gynecological exam from a gynecological cancer, or as infrequently as once a year. But since I'm kind of early in my practice, it's actually really nice. I'm starting to see the people return kind of for their long-term follow-up from their first treatment course. And it's really like, oh my gosh, how are you doing? You know, how is your, you know, how was the return to work, or how was your retirement party, or how's your dad doing? And it's really nice to be able to have both the, you know, acute period of time when they're on treatment where you're really like, you're their doctor because you're seeing them frequently. You're the one managing all their symptoms. And then kind of the long term, like someone else is kind of holding the baton, and I'm just kind of seeing you as like a fun, wacky aunt to come in and be like, hey, how's it going? And so it's a really nice balance of sort of the acute needs and then the kind of long-term follow-up. I'm not sure if that answered your question, but
It actually did, and I think it's a spot-on description of the field. And actually, now that you mentioned your mom was radiation oncologist, I feel like I knew that. I don't know how I knew that. What is like your earliest memory as her daughter of her job, if you have one that you're willing to share?
Yeah, I don't know if you guys have many parents who are physicians, but the thing for me was that my mom never allowed us to have soda or candies in the house. But when we went to work with her, we would be able to go to the doctor's lounge, which had sodas and candy. So that was my favorite thing, was spending quality time with mom when she was on call in the hospital, which I think, you know, now when I think about it, it's like incredibly sad. It's like my quality time with mom was when she was in the hospital. But for me as a child, I was like so delighted by being in this like high-tech environment, and like I was like, my mom is so cool. I remember specifically like she always dressed professionally, like she never wore scrubs. So she was always like put together with essentially like a pantsuit or a skirt suit. And I just always remember thinking like, oh, my mom is a professional. I was like so proud of her and like what she did. And also the doctor's lounge.
That's fantastic. Actually, that kind of, you know, brings me to the next question. What helped you decide to go into the field?
Yeah, so I had never planned on going into radiation oncology because in addition to my mom being a radiation oncologist, my sister is also a radiation oncologist, and my brother is also a radiation oncologist. So we had it covered. Like we were done. We didn't need any other radiation oncologist. I was actually interested in going into geriatrics because I was really interested in caring for people towards the end of their life. And it's not that I do a ton of that now because I treat a lot of curable cases, but there is some overlap with geriatrics and all of oncology because based on the patient demographic. But, you know, I really just, it's that mix of, you know, again, like research into what really matters to patients, and then the actual like hands-on patient care. It's just like such a nice balance. I had originally thought geriatrics, then I thought medical oncology. And I think some of my experiences, you know, shadowing in medical oncology and seeing like all of these conversations about like second line, third line, fourth line chemotherapy, I feel like for what we do, it's so much more, there's so much less gray. I'm going to treat you because I feel like I will help your pain or stop your bleeding or shrink a tumor mass, or it's, you know, to you know, prevent a reoccurrence, but it's not, there's so much less like, oh, we think that this will probably only have a 5% chance of actually working, but we're going to do it anyway because we don't have any other options. I'm not going to give radiation if I think it only has a 5% chance of working. It just like never will happen. And so for me, that helped me make a decision that rad onc was the thing for me, even though I had decided against it like, you know, a year or 2 years before I actually applied. I also did this imposter syndrome thing because I knew that radiation oncology was competitive, that I actually told someone, I remember like specifically, I told my mentor in medical school, like, I'm not smart enough to be a radiation oncologist. I didn't think my board scores were high enough. I didn't think I could do it. But I will say, like, I'm at Memorial Sloan Kettering Cancer Center right now. It's, one of the world leading cancer centers in the United States. Clearly, I was smart enough. And so I don't think that should hold you back. And amazingly, radiation oncology has become, I think, more inclusive. And certainly with me reviewing residency applications, it's definitely more inclusive, because I 100% am looking for people with other experiences, and people that bring something to the table that's not just a relentless pursuit of high board scores.
100% with you there. So that kind of, again, is a great way of introducing the next question, because the percentage of women applying for radiation oncology is about 35% of the applicants, who will give or take, like sometimes it's 37, sometimes it's 32, depending on the year, but give or take is about 35%. Which is one of the reasons we're actually holding this session tonight. What do you see as the key advantages and vice versa disadvantages of the field specifically for women?
It's interesting. So we'll go to the key disadvantages later, I guess, after this question. Women are a rarity. And so, for example, at Sloan Kettering, when we're making our list of people to invite for an interview, we really are looking for a mix. We're looking for an oversampling of women. Basically, we're looking for a 50-50 split of people that we interview. And so just by being a lady, it does give you a little bit of a leg up. And then, specifically in the faculty search as well, I feel like there are more and more, because, there are this many people going into radiation oncology, and then you funnel down to this many people who are in practice, and then you funnel down from there, this many people in leadership, and eventually there's 2 women chairs. So there's still this pipeline problem. So I think everyone realizes that, and they're trying to get people in the pipe. If they then fall out later because of discrimination or poor work practices or work-life balance, we're still working on that, obviously, but it does, I think, help the fact that we are underrepresented, and everyone is, I think, at this point, distinctly aware of it. I think it also allows you to have really great women mentors, because I think women know that we are kind of few and far between. And so, for example, when I did my training at Duke, Manisha Palta was one of my mentors there, and she's a badass. She's like, I really only work with women. It's, if I have a choice and, all things being equal, I'm going to offer this, research opportunity to a woman. And so I was able to write a randomized clinical trial, which is funded with her at Duke, which is a great opportunity. And we specifically worked on projects where she knew that I would be interested in it, not just like, here, this is what you do, but like, how do you make this your own? How do you manifest this into something that you care about that will further your career, your research interests? So that part's really nice too. Like well, if I'm the only lady here, I know probably I'm going to be working with the badass lady mentor. Hopefully.
That's probably how the mentorship should be done in a way, that you're not just, completing a task by someone, but there's, a big part of you in that process. So which kind of brings me to the next question. What do you think of current mentorship in radiation oncology for women? Where do you think, there are some perhaps areas where we're lacking?
So there is a distinct lack in people who are in the upper echelon of leadership. So there's, I think, a moderate amount of middle career physicians who are female. There's a minority of senior ones, and so it's much more like peer mentoring, which I have to say I'm really into. I had never heard that term, peer mentoring, until I joined MSK, and at MSK we're very bottom heavy. Like, we have a lot of female academic radiation oncologists. We counted, there's 21 of us here. There's 21 attending female radiation oncologists.
Nice.
Yeah. But we're all junior basically. So there's like one or two that are senior, but it's, you know, it's mostly junior. But it really fosters this incredible like collaborative atmosphere. We have like all of these great like, you know, social activities, but also like, you know, we give each other advice. We're working with each other on projects. We're trying to kind of co-mentor, you know, the female residents. You know, it's been a really great kind of collaborative environment because nobody is above the other person. We're all just trying to make it work. And that, I think there's actually some power in that because you really can, you feel like, there's no stupid questions. We're all kind of figuring this out. If that makes sense.
Yeah, absolutely. Why do you think there are no women in the leadership roles across the country, really?
Yeah, so my mom went to residency in the 70s, and at that time she was the only female there at all. She had, as previously mentioned, I was raised as the youngest of 7 kids. So she did not go into academia. She had her own practice, and she was the medical director of that. But, you know, there's a lot of sacrifices that you make to go into academia, and it can be really challenging to do that work-life balance. And I think that based on the minority of women that were going in at, you know, who went into, you know, did medical school in the 60s and 70s to get to the point of chair now, there was just a lot of people that kind of dropped out, you know, because of family commitments. There's just, at the time, there's really not a lot of lack of support. And when my mom had her first kid, she took 1 week off. My oldest sister was dropped off at the peds nurses station. And so the pediatric nurses basically took care of my oldest sister during the day. And my mom would run up and go breastfeed her. And I was just like, Mom, you know, those nurses, like their job was not to take care of your kid.
Well, that's one way of looking at it.
Yeah, I mean, you know, I interviewed her recently because I was just kind of interested in some of her stories, and she's a very like conservative Republican person, and she's like, I was never discriminated against. And I was just like, oh, is that true, Mom? Because you just told me that someone put a severed penis in your white coat when you were in anatomy lab, and I don't think that happened to other guys in med school.
Probably not.
Yeah. So that was clearly a message that was sent to women. You know, I think that the women chairs and the women in upper leadership now also came up during a different time. And I'm not saying that they're like mean or harsh or whatever, but I think that it kind of hardened them in some ways. Yeah. Sort of like if you have like a, you know, senior woman in surgery or any of the other very, very male-dominated specialties. And they just have different expectations. I think they're going to give you different guidance even than people who are younger in their field and that are more interested in breaking the paradigm of how we consider medicine, because medicine is too often like, we tell these battle stories about how we were in the hospital for 100 hours every week and how my mom had to give birth and go back to work. Like that shouldn't be the normal. We shouldn't be telling these stories with pride. We should be telling them with shame. Like this is unacceptable and it needs to change. It's not like, well, I dealt with it, so should you.
I absolutely agree with you there, that this is, you know, the paradigm that perhaps needs some shifting, and maybe female leadership might actually be the final force to achieve that shift. Because I've heard a lot of conversations about it, but I've seen very little done about it, to be absolutely honest. Actually, during my internship year, you know, some of my fellow female residents, they gave birth, and 2 weeks later, because that's how much vacation they had, the mom took care of the baby. And like one of them told me, my daughters think I'm their sister because she had like older siblings. And she's like, they think I'm their sister. They don't understand that my mom is their grandma because she's the one raising them effectively, which, you know, really shouldn't be a thing, I believe. Speaking of, you know, women supporting each other and kind of supporting one another, do you think this is perhaps a way of alienating men in the field?
I know that when I posted this to Twitter and it was like women for women, I had a couple of guys that were like, what about men?
I was waiting for them.
Yeah, I was like, men's rights. So I think that if there was no pay disparities, if there was no gender discrimination, if I didn't just recently publish something that showed that about a third of women feel discriminated for being pregnant, then yeah, we wouldn't need to have forums like this. And so I think you still do kind of get that from men who are like, well, can you just give me an example of how you've been discriminated against? And I was like, I'm not going to parade my trauma for you to prove that, you know, safe spaces are important. And so just the idea that there's this term called imposter syndrome that we all feel, that I told someone that I wasn't smart enough to go into this field, that the idea that like, if you toot your own horn, somehow you're, you know, a bitch, you know, as opposed to just being, you know, a go-getter, you know?
Yeah, absolutely. Like the same behavior would be perfectly acceptable from a man, but you know, somehow you as a woman would be seen as bossy if you did the exact same thing or said the exact same thing, which is something that really bothers me. I kind of feel like, you know, the standard should apply irrespective of gender. You know, sometimes I just wonder, you know, how to bridge the dialogue, how to kind of get the men on our side to an extent. And I don't necessarily want to see it us against them, although it really is quite more often than it should be almost us against them. And I'm just wondering, you know, what should be the bridge between these to kind of find a shared ground and support one another really across the board and really focus on perhaps talent and shared values rather than, you know, some tribal aspects of others. I'm just wondering if you had a thought about that.
It's so hard because I make bad jokes too. And I was just like, I know, I'm sorry. It's just, you know, you get so used to making these maybe in poor taste jokes. I think that we're all just trying to improve the field. And I think that there's really good evidence that a diversity of physicians and providers actually elevates the standard of care for cancer. And I think we're also, you know, really trying to create more opportunities for a diversity of, you know, thoughts within the field. So, you know, I do health services research. I'm interested in patient outcomes. I've never pipetted anything in my entire life. I've never done.
Oh, you missed out.
I've never done any basic science research. I'm interested in, you know, the kind of practical mechanics of how cancer care is delivered and how to do it more efficiently. And I am the type of person that I think previously might have been weeded out of this field, but I'm also the kind of voice I hope that will end up improving this field. So I think if we think, you know, if we're opening up the field to different types of experiences and different interests, that can only improve how the patient actually receives their care. Because I did a study on parking costs for cancer treatment, and it was so well received by one group of people, mostly patients, and so poorly received by a lot of people that were like, this study is so stupid. Why on earth do you care about parking costs? And I was just like, because it costs some people hundreds of dollars. And if you're not thinking about that obstacle for patients, then you're really not providing the best patient care, no matter what you think in your head.
It's real money to some people.
Yeah. Real money, like real money, which requires other sacrifices. So if you're not even considering that to be important, then you're not best serving your patients.
Absolutely. One of the sort of reflections that I was able to make was that I feel that men in leadership roles who are kind of genuine, authentic advocates for women, for whom it's not just a token, are, you know, really good allies. And I saw the difference, for example, you know, in our own training, we used to have a residency director who is white male, conservative, has a housewife and 9 children, whom she raises. And now we have, you know, Asian American residency director who is married to a physician who works, who's raising their kids. And it makes an enormous difference how he reflects on my experiences and Dr. Smith's experiences and my other female residents' experiences. So I sometimes wonder, you know, if perhaps, you know, promotion of these people might be helpful for, I don't want to say our cause, because I'm not really sure if there is our cause per se, but for the entire field and the diversity, which I do agree is absolutely critical, not just, for perhaps, selfish reasons such as our own career and job satisfaction, but ultimately for the patient care, because it makes an enormous difference when you have people with diverse experiences versus people who kind of followed a path that they were kind of set up on, thanks to the accident of where and how they were born, really, like the SCS of their nuclear family and all that kind of set them for that. And how do you provide diverse care to diverse people if this is really all you ever knew?
Yeah, I think that just the fact, again, that I grew up in a environment where my mom was a physician, where she is a radiation oncologist, and she was really the breadwinner of my family, that itself, it had gave me such a privilege kind of going into this field, not just because we had an income that included having a physician who, could, the expectation was to go to college and to make something of your life, whatever it was, but also just the model of what a successful woman was, and I knew exactly what sacrifices she was making to have us, at one point she was in private practice by herself, and I really didn't see my mom that often when I was like little, and that's a harsh reality of sort of like, for her being the single breadwinner of the family, being like the only person in her practice, I often would go to sleep without seeing my mom. And that, again, that's the other side of, that can swing too far in terms of the potential downsides of this field, because like there's patient care comes first, right? Like if someone is, if someone needs to be treated, it's late at night, you have to be there, and that's the balance. And for my mom, because she's in private practice and she was in a small town without another radiation oncology facility, she's it.
She has to bear the cross, yeah.
Yeah.
And and it's a genuine sacrifice. Like some people feel like, well, you didn't get to see your case, so what? You see them over the weekend, but it's not really about that, right? When I was an intern, we worked 16 hours a day, South Bronx, that was just something really. And I feel like I missed out on a year of my children, on their life. And I feel like it's a loss that's just, really hard to make up for now, having perhaps a little bit more flexibility. It's just never coming back the time when they were that age. So
I don't have good oral hygiene. No one ever checked to see that my teeth were brushed. When I was a kid, there was my mom never checked. So I have to, it's so hard. I realize this is stupid, but like, I didn't have that kind of parenting of like a mom who was like, oh, I'm going to check to see your toothbrush is wet. No. So for many, many years, I just didn't, I brushed my teeth like once a week. I'm better now, obviously, because I'm like, but yeah, like like that is, it was not part of like when I grew up.
Mm-hmm. Which actually kind of is a perfect introduction to the next question that I received from Jennifer, which is, how family friendly do you think radiation oncology actually is? I think it's a great question to ask.
So I think that there are definitely some assets that are positives, meaning it's outpatient. For the most part, you control a lot of your hours. You can work at home. You can do some of your work from home. You can finish notes at home. You can do contouring at home. So you can leave every day basically at 5:30, depending if you have coverage for the machines, and you can finish things at home. But your clinical volume can be quite variable, and those needs of what you need to do at home can also be quite variable. And so I think that the main deficit of this field is how small it is. So you don't necessarily get a pick where you get a job. And if you are limited by geography or by a spouse who's also a physician, which is, let's be honest, pretty common for female physicians to have a spouse who is either in medicine or in a field that is a rarefied, educated field, that you can't just move to. I grew up in Indiana, small town Indiana, West Lafayette. You can't just move to West Lafayette willy-nilly, where your spouse may not be able to get the law job or the medicine job that they, that is part of their career. I think that many of the senior leadership previously mentioned are old white men, and they may not be as sympathetic to, you know, the shared burden of raising a family, you know, because they had a spouse who was able to stay at home and take care of their 9 kids, you know. And so that is changing, but it's never gonna change fast enough.
Yeah.
And so that part is like a harsh reality to think like, okay, this is a small field. I have a partner who's going into orthopedics, or who's a lawyer, and we are going to be stuck to certain major cities. And will I have a high chance of going, either matching in that city or getting a job in that city? And I would say it really just depends. You know, I'm not as worried about the job market as a lot of people are. I think there's a lot of like, you know, Chicken Little, like crashing down sort of thing. I think you'll get a job, but it won't necessarily where you want to be. For the record, I did not want to be in Manhattan.
You did not?
No, I would rather honestly have stayed in Durham, but Duke job was not the right job for me. They weren't going to give me the projected time to do research that I have here.
Oh, well, you know, I guess, you know, you probably instinctively brought up the point of balances, like, you know, compromises. And I would say, you know, for those participants who are partnered up or married, you know, this is a big consideration when choosing a field. I would say of all the fields in medicine, probably along with derm, we are the most family friendly, I would say, and maybe primary care. Like, I feel like,
you know, so I think, so it depends. So there's internal medicine where you don't have hospital practice. And if you don't have hospital practice, then your hours are pretty good. If you have outpatient hours, then your hours are pretty good. Surgery, you know, is not very family friendly. But, you know, any surgical subspecialty isn't, just because you are by definition in the hospital, emergency medicine, not super family friendly, just because again, your hours. But like anything that's outpatient, I think, you know, honestly, you can find the balance. I think what's challenging about this field, and I'm not trying to dissuade people, is just that, you know, it is very competitive. You know, even if we're no longer actually competitive in terms of board scores, the mentality is still very competitive. You know, the people that are already in the field feel like you have to earn it in some ways, which for some women I think is really kind of like clicks on that competitive vibe, and for other people it just turns them off. You know, like, why can't we all just get along and help people? You know, like, why can't we just treat patients? And I think that's one of the main reasons why my sister and my mom are in private practice now, because they just didn't want to deal with this competitive garbage that can happen a lot in academia, because it really is like, I have this many grants in, I have this many publications, you know, I have this many, you know, protocols going through the IRB right now. And that's just like a rat race that sometimes you know, like, there's always the next step. I mean, like, I did well in med school. I made AOA. Okay, I'm going to match into residency. Oh, I got my, you know, top choice. Oh, I got a faculty position at Memorial Sloan Kettering. And it's just, you know, it never ends. Like, I'm still like trying to.
Where do you say I made it?
I know, right? Sorry, I'm being totally honest.
And I also appreciate it, because it's absolutely true. And part of me wonders, because I was just thinking about this a couple of days ago, like, when I look at the people who are in a way rewarded in academic medicine, which are typically men, typically white, let's be honest, when I look at them as humans, you know, am I always, you know, convinced they are like the greatest characters, you know, like the kind of people they are? And I'm sure people would agree with me that not necessarily always. So when you think about, you know, who's really rewarded in the rat race, it kind of makes you wonder, do I really want to be a part of that? Do I have to become like that to be successful? And, you know, that's something that I feel like perhaps is changing, with people finding a bit more balance in life and kind of, you know, different values perhaps. But I wonder, do you think this has something to do with the concept of toxic masculinity? My favorite topic.
Yeah, it's interesting. Actually, so I feel like, as much as that's a great term, I feel like it's not super applicable to radiation oncology, only because like what we have is certainly masculinity and it's certainly toxic, but it's like under the surface, you know, like we have masked masculinity that I think is a negative force, but I don't it's very rarely just like out in the open, like someone being a dick. It's much more of a like, oh, like you're not good enough, or oh, you're not contributing enough because you didn't, you took time off to have a baby, and you weren't, you don't have as many RVUs because we made you treat breast cancer, whereas I treat something else that pays more. It's even sometimes what women are forced into in terms of like, there's a disproportionate, like when I was up for a faculty position, like, 3 of the 4 positions where I was a serious candidate, like with, where I knew the specific dynamics of the job, 3 of the 4 of them were breast jobs. And I am not, I treat breast cancer now. My interest is in gynecological cancers. And so I happily treat breast cancer. I'm not like, I don't want to make fun of it, but it's not what I was looking for. I was not looking for a breast cancer job. And with hypofractionation, it actually is one of the shorter treatments that we do. So if you're in an RVU based job, you're going to make less money by treating breast cancer. Mm-hmm. And so I think some of that pushing is, from the weird male-female dynamic. So I think of toxic masculinity as being so bold, and I think what we see is much more like, it's much more that gray line that's honestly more insidious and therefore harder to combat. But that's kind of all of medicine, so.
I was actually wondering, I'm not sure if Dr. Smith had to log off, but Tammy, did you have a take on this at all? Because you're going into private practice after all. May have needed to run to her children. In that case, I received this question from Tari. Can you touch a bit more on the differences in private practice versus academia and experiences for women in those 2 spheres?
Yeah, sure. Again, because I am in academia, my brother is also in academia, my sister is in private practice, and my mom was in private practice. We're like perfectly balanced. So I would say that I used to think that someone in private practice has better hours, but that is not necessarily true. I know that from my mom, who worked a lot of hours when she was the only provider within her private practice. But then later on, as she got more senior and she got to hire people, then she had great hours. She decided that she was only going to work 4 days a week, and she didn't even go into the office on the last day because that's what she wanted. And so that was her mix when she retired. I think that my sister in private practice, definitely, like she is a mom. She runs to work every day, 15 miles. Well, there and back is 15 miles. She works that into her schedule. She works essentially 8 hours every single day, and she gets the work done. So I think that it just depends on the kind of the hustle that you have, because I also have a friend in private practice who is now struggling for clients or patients, because,
COVID.
her old partner, who is a white man, opened his own practice in this small town where she's at, and literally took all of her patients with him. And now, she has 8 patients on treatment, and everyone in the facility is freaked out. So I think, in academia, with the MSK name behind me, I'm never worried about patient volume. So there's some security there. You make a lot more money in private practice because you usually typically make partner within 2 to 3 years, plus or minus a buy-in. So I know, again, this is like a mixed blessing story. Please don't take too much into this. But my sister waited to divorce her husband until she made partner.
Okay.
Because she knew that she would have enough income to buy a second home. So
I can see that, I guess.
So she left the house that they had together, and then she was able to just buy another house, like, a mile away, so that she could be close to her daughter, because he was the primary caregiver of their daughter, because he's a house dad. And so, yeah, her income essentially doubled when she made partner. So, you can certainly make close to $1 million in private practice by retirement, which is what my mom did by the time she retired in radiation oncology and private practice. You can make that as an academic, but that's like beyond my plans.
Dr. Smith, I think you had a take on this.
Remind me what the question was again, the difference
between private practice and academia in terms of the benefits.
I think it really depends, because I've been going through the interview process, and I think really it just depends on where you end up for a job. So some of the private practice jobs will keep you there until the machine's over at 7 o'clock every night. And other ones, you can be out of there as early as 3 if you end up going to a rural area. So I think it just depends on where you end up going, but you can make it easily, 8 to 5 every day and have one academic or one administrative day to do your planning and contouring, or you can, have the 8 a.m. to like 7 p.m. job if you really go into a private practice that's really busy. So I think there's a variety out there. It's just depending on what you're looking for and where you want to be, you can get what you're looking for in the end.
Yeah, no, I think that's true, because I think that so my brother, I work way more than my brother does. And he's in academic medicine too. So I just work longer hours. He has 2 small kids. I do not have a cat. His priority is to get home to have dinner with his family. And that's, we all set different boundaries. My boundary is that I don't do work at home. I don't do any work at home. I don't work on the weekends, and I don't do work at home. So that means sometimes I'm here literally at midnight finishing stuff because it needs to get done. But I also don't open up anything at home. I don't, there's no planning done at home. So you all can, make your divisions as it is. I think that one of the benefits of academic medicine, if I can put a plug in, is just the fact that you do have more of an opportunity to do teaching and mentoring, which is really lovely. But that is also more work. I had no idea it was so much work. I think when I have had the benefit of mentorship, I had no idea how much work I was giving to the people who were mentoring me. And now being on the other side of it, it's like, you have a limited capacity for kind of bringing up people through a project.
Yeah, that's actually a great point that, it's fantastic to be a mentor, but it does take time. And we received a question from Judy. I'm curious on your thoughts regarding male rad-onc mentorship. Do you feel like these relationships can be beneficial to female rad-onc applicants or early career physicians?
Yeah, so my main male rad-onc mentor, this is bad, but it's my brother, because I actually worked a lot of projects with him. But I also think it's because we were able to have a casual relationship where I am very dogged in my interests, and I don't want to work on anything that doesn't interest me.
Which is fair.
Yeah. So because of my pre-existing familial relationship with him, I could just go up to him and say, hey, I'm interested in doing this. Is this something that you want to back me up on? And he would say either yes or no. And the ones that he said no to, now it's funny, I've had ideas like from 4 years ago from residency that I'm just now completing because he wasn't interested in it. But I'm finally in a position to mentor someone else into it. So I honestly haven't had like a ton of male rad-onc mentors. It's not that I'm against it. It's just because of my unique interest, and also because frankly, I'm kind of pushy. I don't like working on other people's projects. I want to work on my projects.
You make it sound like it's a bad thing.
No, but that is the classic dynamic in a male-dominated field, is that you just show up in someone's office and you're like, I'm here, use me. And that was never my interest. I always wanted to do something that was of interest to me and could have a meaningful difference for patients, and what didn't necessarily fit into someone's like master plan for their whatever K grant.
Yeah. Yeah, that's a great point, actually. Another question
sorry, just to follow up on that, I think that you can test out people. You can kind of suss out how much people are interested in letting you be you, and you take leadership and ownership over projects, even if it's part of a larger project and yours is just a small thing. If your mentor allows you to take ownership of that and to actually kind of figure out a way to make it your own, then that's a good mentor. If they're only interested in what you're going to give them, then that's, kind of move on.
Yeah, that's a great point, actually, that, that person who lets you be you is really an ally. And it can very easily be a man. Now, how do you find him? How do you identify him? It's probably a tougher question. And I guess you won't know until you try.
Well, so for me, because I'm interested in health services research, and this is still a growing field in radiation oncology, it meant reaching outside of radiation oncology. So my primary mentor in medical school and through part of residency is a medical oncologist, who is not anyone within my department. And I think that's, it's really nice to be able to have this full, multidisciplinary collaboration. And I think the field is very open to that. Anyone within cancer care that's trying to improve cancer care delivery, wherever you end up, they should be open to that, because if they're not, then they're not, they're not serving patients best. But yeah, it's getting the right person to get you to where you want to go, whether it's private practice or an academic medical center or a residency in Harvard, or you want to stay on you want to stay in California, so it's got to be at one of the UC programs. Your mentor should be giving you opportunities and also sponsoring you for potential ways to further your career.
Yeah, absolutely. I will say that my first real mentor was actually a neurosurgeon, and he definitely, got me started on the path that I wanted to be at. The question that you received that's very practical, and I think it's important to discuss it as well, is how to choose away rotation. You just mentioned that, if you want to end up in California, it's probably a good idea to do an away there. But do you have, any take on how to best choose away rotation, and perhaps how many you should do to be really competitive for the residency slot?
Yeah, so in some ways, I'm a bad person to answer this because I didn't do any away rotations. So I come from Duke, and Duke makes it exceedingly hard for you to do an away rotation. However, I know now that you can't get away with only without doing none. So I really think it depends on what you're interested in doing. So if you have the chops to match in an MSK or a Harvard, and that's what you want that aggressive, nose to the grindstone, big name, bright lights, then you need to do a rotation at the brand name MD Anderson, MSK, Harvard. If you're interested in like a good solid residency program where you get good training and you have a lot of opportunities, but it's not like your name is going to be up in lights and you're going to be crying yourself to sleep every night, then you should do away rotations at Johns Hopkins or U Washington or the UC schools or Ohio State. You should do I hate to call this like top tier, middle tier, but radiation oncologists feel this way, so we can't you should do more of the state school sort of thing. And so I think it just depends on what you're interested in, realistically, how you're positioning yourself, because I will be honest, it was a blessing for me to not match at Harvard for residency program. And I have no hatred towards the Harvard program, but I do know people who've gone through it, and I would not have flourished there. So me doing a residency, like a rotation there, would not have benefited me at all, other than I guess to say, oh yeah, I really don't want to come here. So you know what I'm saying? It's like the rotations are all just who you're going to interact with and how can you impress them.
How many aways do you think is reasonable for a medical student? I would say 2.
I would say 2. Yeah, I've definitely seen 3 or 4, but that seems like out of control. I think 2. I think, one in a school that's kind of in your area, that's not going to be very expensive to go to, and then one kind of reach school would be very, very reasonable. And yeah, I guess it's true. You can be inspired by going to some other places. I feel like for the way I've seen it kind of manifest is that for people that are coming from whatever, they just end up being kind of like judged, for lack of a better term.
Dr. Smith, do you have a take on the aways?
Yeah, I did 2 away rotations, and both were in Florida to try to stay in that area. And it was actually very helpful in some respects and kind of limiting on the others, because then when I interviewed in other places, they were like, well, where did you do your away rotations? and everything I had done was in Florida. So they said, well, would you really come here? The answer is yes. I matched at Ohio State, but it was cheaper for me to stay in Florida because I didn't have to do an Airbnb. But I'd say, you know, like one in like your home state or where you want to go, and then one kind of just like a reach school, maybe to get that letter to see what other programs are like. I did one program was my home and that had 2 residents a year. Then I did one program that had 1 resident a year. And then the last program I did had like 10 residents, and it gave me an idea of what I was looking for. I realized I didn't want a program that was just 1 resident a year. It was just too small for me. And I wanted a bigger program. So I think, you know, going to see different programs gives you an opportunity to figure out like what you're looking for in a residency, because that's where ultimately where you're going to get your training. But we are such a small field that you're going to have good training pretty much wherever you go. It's just kind of a matter of where you fit in the best and where can you see yourself spending 4 years.
Yeah, and I think there is that connections of like who's writing your letter and how much time can you spend with them, and how are you going to impress them, and how much you want to try to hustle for that. And I realize I'm giving you a total negative. Maybe again, it's my reflection of the fact that that I feel like away rotations they just cost money, and I kind of hate the fact that we make people do multiple ones just to get an opportunity to maybe get a letter from a chair who will write you the same letter that he wrote to every other medical student.
Yeah, that's very true, actually. That sometimes, you know, when I review the applications, I'm like, I feel like I've read this somewhere, you know?
Well, and that's why I always feel like the people that you are going to write you the best letters are the junior faculty, the ones that really know you, that can speak to what you do, because like it's important to have a good letter from the chair, but what they're going to write for you is going to be pretty generic. Unless you're at a place that is small and you can really get to know and work with the chair. So that maybe is the advantage of going to a program where, you know, they have a brand name chair, but they don't have that many people. So you actually spend a lot of one-on-one time. And that's kind of the push-pull of these away rotations, is that you can't really define your schedule, and it's kind of the luck of the draw, and you may or may not spend a lot of time with people that actually can help you. But then, you know, you might get that experience like at MGH where you really feel like inspired.
Absolutely. Which kind of brings up probably the last question we have for tonight. I'm being mindful of everyone's time, which is, are there different considerations this year for applications during COVID, such as, you know, limitations with away rotations? And do you have advice for those who will be applying in the pandemic, you know, how to perhaps make up for this?
Yeah, because of the artificial kind of downward push that the pandemic did, you know, we still count like virtual rotation. So people like who, you know, virtually rotate with us, we still honestly give them a leg up if we know them and we feel like they were good in clinic. And so it's always unless you are catastrophic in your virtual or in-person away rotation, it will always improve your chances of matching at that place. It may not improve them to the point at which you will match, but it will, you know, increase your kind of standing. I think that, you know, more than away rotation, I'll be honest, the thing that will really get you a leg up at various institutions is to actually do research with people. Even you can do this remotely. You don't have to be. I am working now with a resident in Florida. I'm working with Bismarck from Ohio State. I'm working with 2 people from NYU. I'm working with like doing these research projects with a number of people that are not at MSK, who are residents or medical students. So you can do research with people in that institution, and you know, my letter of recommendation and my advocating for you in the committee meeting, in the rank list, is going to be way more important, like, you know, because I've actually worked with you. And so that's actually, I would say, if you're going to spend time doing something, you know, actually find someone at the place you want to be and try to start a research project with them.
That's 100%, you know, the best recommendation to give. And I can attest that, you know, in our own faculty meetings about candidates, this plays a huge role, and perhaps, you know, has far greater impact than you having a letter from the chair at Harvard, to be absolutely honest.
Yeah, it's funny. So we, there's someone who who is not on this call, thankfully, who like imposter syndrome, didn't even apply to MSK this year for residency. And we, you know, basically her primary mentor here at MSK was like, why, I didn't even see your application, what happened? And she was like, oh, I didn't even apply, I didn't think I could get in. And like, she was like, what? And so shoehorned her in because basically we reviewed her application, saw that she met the certain whatever, and then she had all these strong letters of recommendation here. So she actually got a interview here, despite essentially applying literally at the last minute. It was like the day we were sending out the application, the residency interviews.
Isn't it tragic that someone feels so insecure that they don't even bother applying? They feel like I'll just never get in.
So
was it a woman?
That she had done research at, yeah.
Yeah, I feel like this is a female's cross to bear, you know, that we feel like, you know, we're never good enough for things that we absolutely deserve.
Yeah, yeah. And I mean, I think I feel like I see that again and again, you know, and again, we're like, you know, MSKs, we have such a stick up our butt in terms of like how important we are. Like, who cares? Like for us, like I went to Duke. I would much rather you guys go to Duke than here.
I love Duke. I did my summer research there.
I just feel like it's a better experience, and it's not like we're mistreating our residency, but I just feel like it's a better balance. But that's just my own 2 cents.
All right, well, we have reached 8 o'clock. Do we perhaps have time, because I'm very mindful of your time as well, for one last question?
Sure.
Which I actually really think is important to discuss. How do you foresee the role and practice of radiation oncology changing in the coming years? Which I feel puts off a lot of people from applying as well.
Yeah. So it's interesting. So we're basically evolving as a specialty to be more precise and towards hypofractionation, which is less treatments, but the more precision, that's less treatment, but then more precision is actually more money. So I feel like the money is still there. And, you know, in terms of hospital systems, the radiation oncology and the surgery department are the only 2 departments that consistently make money. So basically every other department are loss leaders. So we are still essentially very, very valuable. And I think it's that balance of trying to essentially, I think there was an overexpansion of residency programs, but it's overexpanded to the extent where people aren't like, we need to be frank about, you know, like my sister in private practice is in Macon, Georgia. If you asked her 5 years ago, 10 years ago, if she wanted to practice in Macon, Georgia, she I think would have said hell no. You know, she likes being there. You know, it avails her a good lifestyle. She has a lovely home. You know, she is an hour drive from Atlanta, which she loves, but it's not like she never would have picked Macon, Georgia, like as a position, you know. And so I think that there's still that, you know, again, it's a small field. We are becoming more and more concentrated. There's more and more academic medical centers and private practices that are building up these huge conglomerates. So that itself is a consolidation of, you know, there are more and more positions that are not even kind of real positions. Like my friend just, you know, has her position is essentially a float position where she basically subs for a bunch of physicians. And, you know, like that's not a great role either, you know, it's kind of not what she thought it would be. But that doesn't mean that, you know, she's not doing something that she likes to do. It's just not ideal for her. So that would be better for a retiree, I'm guessing. So.
You know, radiation oncology still needs the human contact, the human touch, unlike radiology, where I actually do think the threat of AI is very, very real, which is why everybody's kind of flocking to interventional radiology. And similar perhaps to pathology, where I feel, you know, ultimately, you know, the diagnostic process will be replicated one way or the other in the computer. Do you think we will be replaced by machines or NPs perhaps? That's another consideration, I think.
No, I mean, we have a lot of NPs here, like we really do. And I really welcome the NPs to lead survivorship clinics, to offload my clinic of follow-ups. But no, I really don't think that. because what we're doing is actually becoming more and more precise. It's becoming more and more technical, you know, because even the decision-making process of who I offer whole breast radiation versus partial breast radiation and 3 fractions versus whole breast radiation and 5 fractions for someone with, or versus omission. So for someone with an early stage breast cancer, they can literally have 5 options, and that shared decision-making process is very complex. And being able to actually say, you know, these are how these 5 different potential treatment options compare to each other. This is the evidence to support them. This is why I recommend this one for you. That is complex decision-making.
All right, 8:05, and I feel like I'm losing control of my Zoom as usual. But I feel like, do you have any wrap-up comments for us at this moment?
No, I feel bad. I'm like been too casual. Like I'm gonna regret saying what I said. So please don't quote me.
No, I actually really do appreciate your honesty, and from my point of view, I feel like we don't get enough of this, to be honest, in medicine, and that, you know, people sugarcoat things unfairly, and then, you know, perhaps people are disappointed where, you know, things don't necessarily meet the expectations because they were never given in an absolutely honest light. And, you know, radiation oncology, I don't think it's an easy field. You know, some people choose it for the wrong reasons, such as the salaries and the lifestyle. But at least from my perspective, I feel like it's a tough job when you see young patients or even kids that are really suffering from something that you actually have no power and no control over and really have no options to offer. So I feel emotionally, it can actually be quite challenging. I was wondering if you had a take on that aspect of the job as perhaps the last thing.
Yeah, you know, so I'm a young widow. My husband died of cancer when he was in his 20s. And one of the reasons I was interested in geriatrics is because I never wanted to see someone like my husband. So I figured if I was only in clinic seeing patients who are 65 and older, that I wouldn't have to encounter that kind of heartbreak. Obviously, that has changed, and unfortunately, I do have very young patients with horrible disease. The way I deal with it is that I know that if I am offering treatment to someone, it stands a very good chance of actually helping them, of improving their quality of life. And even again, have seen horrible situations of young women with young kids with metastatic disease. At least I can help them become a little bit more functional. And radiation doesn't always work, but it often does. And that's what I can offer people. It's hard though, you know, like I have a young man right now who literally reminds me of my husband because he is so skinny and he's like tall and skinny and he's still trying to work. And I have conversations with him, I have conversations with his wife, and it's really hard not to just break down crying. But also, like, you know, I am confident that my treatment did improve his life slightly, not a lot, you know, it's not a miracle thing. But I do think it has made his life a little better. And that's not nothing, you know?
And there's meaning in that, I think. You know, you don't win every battle, and I will, you know, give an official warning to everyone that 60% of the patients you treat are really palliative. You know, the numbers just add up to that typically. And it's something to be mindful of. Granted, most of them are on the elderly side, as you mentioned. You know, geriatrics is like perhaps one aspect of looking at it, but not all of them are. And I would say if you're considering that skill, this is something to take into account, perhaps more than location, salary, and some other lifestyle aspects. Are you able to handle this kind of patients and be a good doctor for them? You know, are you able to connect with them and kind of accept that this is the reality of your life?
I would say my balance is probably 70-30 in terms of curative, but I also treat a lot of breast cancer, and that's just a lot of early stage, you know. I treat mostly curative cases, but anyway, so it is 8:10. I'm happy to hang around for like a little bit if you guys just want to ask me random questions, like a one-to-one, but it's up to you, Nicole, if you want.
I'm more than happy to hang around. I'm not sure if people have somewhere to be. If they don't, please use your hands or ask a question in the chat. I'll be happy to read it off. Because I got control of Zoom again, yay. I feel like, you're into the pandemic. Shouldn't we like all be really proficient with it? I will, I'm still not. All right. Oh,
So
and I actually meant to ask you, do you have a research project that you could use the help with by some of our perhaps talented, motivated students that joined us tonight? Is it okay if they reached out to you?
sure, yeah. I mean, I just have some project. The thing is that it's all about like getting stuff done so it's deliverable to what serves your purpose, and then whether or not I can actually handle an additional like mentee, basically. I think that
Right.
Tanvi had wanted to ask a question, but yeah. I don't know if you need to manually unmute her.
Tell me, I will try to unmute you, see what happens.
I think it worked.
Oh, hey.
Yay.
Awesome. Hi, everybody. Thank you so much for your time, Dr. Chino, and thank you so much, Dr. Molitova, for just moderating all of this. I thought it was immensely helpful. I'm Tanvi. I'm a third-year medical student at Georgetown. I'm so inspired. I'm applying to radiation oncology, but I feel anxious this year with everything being virtual, with the conferences being virtual and the away rotations being virtual. So my question to you is, what piece of advice do you have for somebody in this situation? How can I make the best of this application cycle? Or is there anything that you have found in the last year to be helpful or not helpful, or any pitfalls that you can sort of warn me against, or really anything? I'm first generation. I'd really appreciate any advice.
Yeah, so I think that it is, you cannot understate how important basically your personal statement in terms of actually like telling a story, because I 100% read all of the personal statements. For rotations, your actual, like you usually give a conference, and how even if I don't work with you, I'm probably going to see your conference. And I actually pay attention to conferences, and it's like a good opportunity for me to refresh on something. So you don't need to like necessarily like teach me something new, but it's really like the medical student conferences in terms of like summarizing what we know already is actually like a really nice review. So those are actually very helpful. And I think in terms of the actual kind of like the interacting with people virtually, I think it's just a matter of being like enthusiastic and having done some reading. So you don't have to be the expert on everything, but if you can read ahead about one patient and then know what to do for that one patient, that really makes a difference. Or if you can provide some additional history, if you're doing a virtual consult with someone, if you're able to actually talk to the patient and get the full whatever, like I'm interested in like, who is the social support, like who can help them, what are the potential barriers to getting care. That's the sort of thing that like medical students honestly are great at, because you have the time to do it. I want to know, it means that you've thought about that, about the potential barriers for someone receiving, like, radiation is a daily treatment. It is hard to get there. Like, what is, like, how does this person drive? Like, who lives with them? Those are all very important aspects. So again, it depends on the setup of your virtual rotation, but I would say, yeah. Actually being helpful, you'd be surprised how much that is like a huge benefit. And I'm not trying to be like medical students aren't helpful, but if you can contribute in useful and unique ways, that really,
we all will notice.
Yeah, that leaves a lasting impression, which is like, that person was amazing. Like, they went the extra mile and they made that phone call. They coordinated this care with their cardiologist to get the pacemaker information, or like whatever, like that really does make a difference. I would not waste your time doing stuff that is meaningless, which is hard, but like, if you're like, I'm trying to think of things that are like not that people do, but that are not, I just feel like, endlessly like memorizing facts is not, like, clinical trial numbers are not super important. I mean, they are, I guess, in general in residency, but they're, I think, less important for medical students. I think just like knowing how to actually take care of patients, knowing that there are guidelines, that you should just follow guidelines,
and show that you care. Like,
Yeah.
nothing bugs me more when I have just a sense or a vibe from a student that, he's like making sure to impress the residency director, but otherwise doesn't care at all about the patients we're seeing. I mean, and people will tell. We can pick up on this very easily. So I would say, if you don't care, don't bother showing up. Also, I would definitely second the personal statement that we all read them, we have time to read them, we have 200 applicants a year, so we'll read every single one of them, and you can really make a huge difference in terms of how many interviews you get. If you have honest, well-written story, good statement, it makes a huge difference. And we often comment like, the statement was blah, for someone who has perfect scores, for example. So absolutely put effort into the statement. That's really your way to showcase why you're in this, why you want to do this, and why you think you're the right candidate for this job. Tammy, you wanted to add something?
Yeah, I'll go from the other side because I've been interviewing for jobs. So I think also, you obviously want to make a good impression on whoever you're speaking to, but you also want to figure out if this is a place that you feel comfortable in. So similar to like what I said for an away rotation, you actually can tell. You can actually tell pretty easily who you fit with and who you don't, even if it is a virtual interview. Because I can tell you, I've had interviews where I'm like, okay, this is a really awkward virtual interview. And then I've had some interviews that it was like I was sitting across the hall from the other person. So, or, in the same room. So I think that's important to know when you're going through this, that you want to find a place where you feel like you can just have a conversation with the person, even if it is on the other side of the computer.
Yeah, absolutely.
Yeah, I would say like the other thing is don't be just totally enamored by a brand name, because sometimes those residents are miserable and you can tell. Like just because some place is a prestigious place doesn't mean that they're going to give you the training that's right for you. And that's my joke about Harvard, is that like, it wouldn't have been right for me, even though it's much more prestigious than Duke, because I would have been miserable there. I know.
They'll work you hard, these places.
I mean, this is what's funny, is that every residency think that they work the hardest.
Mm-hmm. We sure do.
Every single place is like, oh, we work hard. And it's just like, like who knows?
That's absolutely true.
There's very few places that are like, oh, it was easy.
Yeah. Although I do have to admit that there were people, some fellow residents, who said, yeah, like my internship, I like moved from New York and I had like 300 hours sleep deficit after that year. They were like, you know what? I didn't even use up all my vacation days. I was like, what? Like, how does that work? So that's probably something.
I think Alice had a question.
Oh, of course, Alice. I will try to unmute you.
Hi. So at the minute, I'm a medical student in the UK at UCL, University College London, and I'm considering applying to the US for residency, although it's potentially quite a long way away because I'm applying to Sandwich a PhD this year as well. But one thing I really wanted to ask is about if you've got any recommendations about going to get any research opportunities or clinical rotations as a future non-US IMG, because there's quite a lot of barriers, including that you have to be at a US medical school or you have to be a US citizen, and I'm currently neither of those, so it's really difficult. But thank you very much. If you've got any advice, that would be really, really appreciated.
Yeah, so mostly I know that in terms of like IMGs, like in terms of it's a harder bar to pass for at least getting a residency like slot, because of the lack of, everyone in the US, basically the residency program gets money for training them. So the residency program gets paid, I don't know, like $35,000 a year to train them, and then they get the free labor. So the IMGs don't have that. In terms of the actual, like just, doing a research elective or a away rotation, I think that's probably a little bit more liberal, although I'll be honest, I don't have a good experience there. You probably have maybe more luck just contacting people specifically and say like, how do I get this done? Because I think that can remove, if you go like the institution level, like sometimes is easier for me to like push like from my end than it is for, for you to, be outside essentially, trying to connect with whatever administrative assistant who can help you. It's like, it would be easier for you to like contact me and be like, I'm an IMG, can I do a rotation at MSK? And then I'll be like, I don't know, let me actually contact, Nicole, who's the person who does that, and she will walk you through it, as opposed to you being like, impenetrable fortress of academia, who do I even contact? So I think that if you have someplace you want to rotate at, I would just pick someone there and be like, I just read your New England Journal of Medicine paper about whatever. I loved it. I would love to do a rotation. What steps can I do? I'm coming from XY institution. Does that make sense?
Yeah, oh, thank you so much. That's really helpful. Thank you.
Mm-hmm.
And I will also say here is where the brand names come actually handy, because they have experience with international students. So if you email East Medical College of Tennessee, they have never heard of IMGs, and they'll be like, where's England? But if you contact Duke, Harvard, they actually have a system in place to get you over. Also, you have to be enrolled as a medical student. You do it as an elective. So once you graduate, you're actually not eligible for any of that. But while you're still in med school, it's the time to do it. And there is some way of essentially taking the course you'd be taking in England there, like for credit. And that's how it works. You have to pay often tuition fees for that. It's the only thing to be mindful of. Sometimes you have to pay.
I will say, from what I've noticed from people who are looking for jobs, who graduated and did residency in other places, if you do a fellowship, which I don't normally recommend, but if you do a fellowship in the United States at one of the brand name institutions like MSK or MD Anderson, even if it just gets you in the door, basically. And so then you'll have established those relationships and you're much more likely to get hired. Again, that's kind of later on in your career, but just FYI.
Oh, thank you so much. No, that's really helpful. Thank you.
Trying to see if we have any other questions there. One question that came through was, can you interview while pregnant?
Yeah, so you should, obviously, because you can't stop. Yeah, and I honestly feel like if you get a bad vibe from a program because they looked at you sideways because they're pregnant, that you're pregnant, then you know the answer that you shouldn't go there, basically. So yeah, you think you should. It's first of all, pregnancy is protected, and second of all, if you want a family-friendly program, and they're looking at you sideways because you're pregnant, then again, that's like not the place for you. And in fact, I knew I wasn't planning on getting pregnant during residency, but I made sure to ask every single program, what's your maternity leave? Who here in the program has had babies during residency? Because that gives you an idea of how female friendly the program is too.
Absolutely, and it's a critical question to ask. For example, I wear a wedding ring, so during one of the programs, they're not supposed to ask you, but they ask me, I see you're wearing a wedding ring. Are you married? And so like that program was dead last on my rank list because it's a completely inappropriate question. Like, why are you even asking me that? So, it's those little things perhaps to pick up on while you're interviewing. All right, so 8:23. I do most appreciate everyone's time. I think it was a fantastic discussion. I will bid you good night and warmest regards to New York to Dr. Chino. And anybody has any questions, you have my email. I'm sure you know how to look up Dr. Chino's email if you want to reach out to her. She said she might have some research collaboration that may work after all. So I will leave that in everyone's capable hands. And unless there are any last minute comments, questions, I will wish everybody good night. And I will put this online and send you the link.
Okay, bye.
Bye, good night, everybody.